Hello, Ricardo.
Hello, good afternoon. How are you?
Hello, Ricardo. Thank you very much for being with us. We are in the end of our meeting. After 3 days, we are going to finish with your roundtable. Thank you very much for being with us and present this roundtable. You are going to chair, so you have the word to this. Thank you.
Okay, thank you very much. So really, thank you very much, Carlos, and all the organization of the meeting in Porto. It is a nice tradition to go to Porto to do this, to participate at this meeting. Unfortunately, due to the COVID situation, nowadays is a little bit more difficult to go in person to abroad, but anyway, we can collaborate in this unique meeting from Barcelona, and that's what we are going to do today. And we have prepared I think a very nice round table to end this meeting, devoted to a topic which is really the state of the art, is lupus nephropathy, a change in the paradigm. In the recent years, we are probably changing the way that we address lupus nephropathy. And we have decided to talk on this topic in a multidisciplinary way, from the pathology to the clinical activities, both from the nephrology side and from the autoimmunologist side. And we are going to start with the pathologist, which is a very important person in the team. I would like to stress the importance of having a good pathologist in the team, who is going to talk on the new insights in diagnosis and prognosis from renal pathology. And the person who is going to address this topic is Dr. Adriana Garcia. She is our nepropathologist. She is from the Department of Pathology at the Hospital Clínic of Barcelona. Since many years, she is helping us in the diagnosis of our lupus patients from the pathology side. So, Adriana, the podium is yours.
Thank you, Ricard. And let me share. Okay, it's all fine?
Yes, perfect. Thank you.
Okay, good afternoon, everybody. I want to say thanks to the organization for your kind invitation. And today, as Dr. Cervera says, I'm going to talk in the next 25 minutes about new insights in diagnosis and prognosis of lupus nephritis from renal pathology point of view. First of all, some key points that I want to share with you. Lupus nephritis is a severe manifestation of SLE with significant morbidity and mortality. Currently, up to 20% of patients progress to end-stage renal disease within 5 years of diagnosis. Up to 60% of patients with SLE develop lupus nephritis, and it typically occurs early in the disease course, mostly within the first 6 to 36 months. Some risk factors for the lupus nephritis include a younger age, male sex, and non-European ancestry. And we know that Black and Hispanic patients have worse outcomes and are more likely to progress to kidney failure than white patients. And it's important to keep in mind that the lupus nephritis is the most common, but not the only cause of kidney injury in SLE. And this is one of the reasons for which kidney biopsy is highly recommended in these patients. In fact, main guidelines for the management of lupus nephritis elaborated by rheumatologists and nephrologists from America and Europe based the treatment recommendation on the 2003 International Society of Nephrology and Renal Pathology Society classification system. So what are the indications for renal biopsy in patients with SLE? A kidney biopsy recommended when urine protein excretion is more than 100 milligrams per day, or any level of proteinuria with decreased glomerular filtration rate that is not attributed to another cause, or hematuria with active urine sediment. Now, what can you as clinicians expect from pathology? The purpose of renal biopsy is to confirm the diagnosis of lupus nephritis, establish pathologic patterns of lesions, and determine the extent of activity and chronicity of renal injury in order to guide the therapy and provide prognosis information. So let's focus on the renal biopsy. First point, is it lupus nephritis or is it a different disease? We currently understand lupus nephritis as a glomerulonephritis associated with immunocomplex, characteristically with a full house pattern, which means deposits of immunoglobulins IgG, IgM, and IgA, and complement C3 and C1q. Those deposits look bright green in the picture. Other causes of kidney injury in patients with SLE are the thrombotic microangiopathy, which is present in up to 50% of biopsies. Around 2% of patients with SLE and nephrotic syndrome has lupus podocytopathy with a diffuse food process effacement without immunodeposits. And biopsy can show other lesions such as tubulointerstitial nephritis, renovascular disease, amyloidosis, or so on. Well, second point to result in the biopsy is where are located the immunocomplex. And with this illustration, I'm going to show what are the possibilities. On the left of the screen, there is a glomerulus normal area with a green podocyte with normal food process, a regular basal membrane, a yellow endothelial cell with normal fenestration, and the mesangium with extracellular matrix in gray and a mesangial cell in red. The immunocomplex can be located exclusively in the mesangium or within the mesangium and the subepithelial area. This is the membranous pattern, or within the mesangium and subendothelial area. And those immunocomplex locations are related with the pattern of lesions that are summarized in the ISN RPS classification. The classification recognizes 6 categories named as class 1 through 6, in which classes 1, 2, and 5 are not proliferative. Classes 3 and 4 are proliferative, and class 6 is a diffuse chronic damage. It is important to keep in mind that the nomenclature 1 through 6 does not imply natural history of the disease. That means a patient does not begin with class 1 and then go to class 2 and class 3 or so on. In fact, we can have biopsies with mixed classes, such as class 3 plus 5 or 4 plus 5. Or for instance, a patient can debut as class 4 which is the class more often diagnosticated, and during the follow-up in a neobiopsy, because a flare can have class 3 lesions. Let's start with pathology images. Class 1 is defined by normal glomeruli in light microscopy, as you can see in this glomerulus staining with PIS, but with a positive immunofluorescence within the mesangium. In class 2, there is a reaction to those mesangial deposits with a mesangial cell proliferation. As you can see, the mesangial areas are more evident with more nuclei inside. In class 5, we observe the subendothelial deposits with this pattern of green dots drawing the capillaries. And in light microscopy with silver stain, we observe thick capillary walls with the spikes, because immunocomplex are not staining with silver. Then classes 3 and 4 with less than 50% or more than 50% of the glomeruli affected, respectively. Those classes have proliferative lesions, usually associated with subendothelial deposits that we can see on the immunofluorescence, like ribbons. And those subendothelial deposits induce endocapillary hypercellularity, and the glomerulus seems full. Subendothelial deposits can also be observed in light microscopy, as you can see in these 3 images corresponding to PAS stain, trichrome stain, and silver stain. And deposits are deep pink with PIS, red with trichrome, and pink with silver stain. And here we have massive subendothelial deposits that fill the capillary lumens. As I mentioned before, those subendothelial deposits induce endocapillary hypercellularity that can be associated with fragmentation, with nucleus fragmentation of karyopexis. Also, they can damage the capillary wall, causing fibrinate necrosis. And proliferation of epithelial cells forming crescents. In this picture correspond to trichrome stain. We also observe subendothelial deposits and endocapillary hypercellularity. Here we have some small cellular crescent, endocapillary hypercellularity, and karyopexis. The glomerulus can have a segmental damage, which means involvement of less than 50% of the tuft, or diffuse damage, which means alteration in more than 50% of the glomerulus. The previous lesions that I showed to you are active lesions that can be progressed to chronic or scarring lesions, such as fibrous crescent or glomerular sclerosis. So the classification of 2003 ISN RPS summarized lesions observed in classes 3 and 4 as active glomerular lesions and chronic glomerular lesions. But although many studies documented the importance of renal biopsy and the ISN RPS system in management of patients with lupus nephritis, the inter-observer agreement in terms of definition of lupus nephritis class or activity and chronicity had some problems. As you can see summarized in this graphic, in different studies, inter-observer agreement was poor or moderate in most of the evaluated variables. And probably these problems with correlation are related with the different interpretation of the parameters that have to be evaluated for the diagnosis and classification of lupus nephritis. In order to solve these problems and optimize the lupus nephritis classification, a group of expert nephropathologists led by Dr. Bajima from Netherlands and Dr. Fogo from the United States worked together with the main goal of improved definitions and also determine some aspects that should be addressed in the future with more evidence. This approach was summarized and published with 2 levels of recommendation. Level 1, corresponding to definitions that were adjusted, and level 2 corresponding to issues that can be validated or modified through an evidence-based multicenter study involving scoring of all separate parameters related to clinical outcome. Some of the improvements level 1 were adjust the definition of mesangial hypercellularity in congruence with the definition in other glomerulopathies, such as IgA nephropathy. And the new definition is more than 4 cells in area of mesangium. Then another change at level 1 was replace the term endocapillary proliferation by endocapillary hypercellularity. And it was because the increase in the number of cells within capillary lumens usually depends on influx of inflammatory cells more than the proliferation of endothelial cells. In fact, there is evidence about presence of endocapillary lymphocytes and recovery of estimated glomerular filtration rate. And sorry. An important precision made at level 1 was the definition of cellular, fibrocellular, or fibrous crescent, because these lesions have different impact in the prognosis of the lupus nephritis patients. Cellular and fibrocellular crescents are related with lower estimated glomerular infiltration rate during follow-up, whereas fibrous crescent are associated with progressive glomerular filtration rate decline and end-stage renal disease. They also adjust the definition for fibrin necrosis as present of fibrin associated with basement membrane disruption or lysis of mesangium. And this particular lesion is associated not only with end-stage renal disease, but also with probability of renal flare. So what about segmental or global lesion? This definition between more or less than 50% of glomerulus involvement. The consideration was to remove this categorization because of the large interobserver variability. And the final level 1 recommendation was to use the modified activity and chronicity indexes for all classes of lupus nephritis. This is the only part of the classification that include parameters of the tubulointerstitial compartment. Those are the interstitial inflammation for the activity index, and the fibrosis and the tubular atrophy for the chronicity index. So what are some of the conundrums that need to be solved in phase 2? First, it is desirable find a threshold between class 1 and class 2 because current more than 4 cells in one mesangial area of one glomerulus is enough to define class 2. And this seems not relevant in the biological point of view. Currently, we know that mesangial cells are the glomerular stromal cells with functions related with control of inflammation and regulation of fibrosis. And defined cutoff values for number of mesangial cells and inflammatory cells within the mesangium could have clinical implications, as well as defined cutoff levels for number of inflammatory cells within the capillary lumen, or define the role of endothelial cell swelling that seems to be more related with thrombotic microangiopathy. A particular question that is waiting for answer is the relation between fibrotic necrosis, crescents, patterns of autoimmune deposits for immunofluorescence, and ANCA serology. Are these lesions ANCA related in patients with SLE? We don't know. There is scattered evidence. There are scattered cases reported, but we need more evidence. And finally, is necessary develop a scoring system for activity and chronicity using an evidence-based approach. Currently, in different series, it has been demonstrated that the chronicity index has correlation with the renal survival and with renal function decline. By other hand, as was present in this study by Robin and Coles, the activity index seems to be useful in the context of second biopsy after complete clinical remission in order to predict renal flare. This is another relevant point to clarify based on evidence. Equally important is establish the implication of non-immunocomplex mediated lesion in the glomerulus, like lupus podocytopathy, and lesions of the other compartments, the other compartments like tubulointerstitial lesions and vascular lesions. Those are the dark side of the actual classification, and we need to know what significant have this lesion for the clinical outcome. In conclusion, the ISN RPS 2018 review classification for lupus nephritis designed the route to move toward a more effective and more reproducible classification with more clinical impact in the setting of a changing paradigm. And thanks for your attention.
Thank you very much, Diana, for your very interesting presentation. I think it is clear that there are changes, there are news in the field of renal pathology. We are going to present all three talks, and then I think that the discussion, the question and answers, we will put all together at the end of the workshop. So let's move to another change in the paradigm. in addition to the immunosuppressive therapies, the steroid, the biological therapies, and the immunosuppressive therapies, and so on, something that it's very important is probably to know which is the patient that will require each of these therapies. And then probably omics, proteomics, genomics, and so on, probably will be the clue. And so that's the reason that we have a lot of expectations from the omics. And this is the topic that Luis Quintana is going to address today. Luis Quintana is leading the Department of Nephrology in our hospital, the area of glomerulopathies, and is our nephrologist of the autoimmunity team. So, Luis, thank you very much for participating at this workshop. The podium is yours.
Thank you very much for the nice introduction, Ricard, and thank you very much to the organization for inviting me to present in this important meeting. Let me share my screen. Do you see it properly?
Yes,
okay.
Yes, perfect, thank you.
So I strongly believe that at the end of a story, the omics approaches will make that some things happen in the field of lupus nephritis. But in order to have these improvements, I mean the clinicians, must have very clear what are the needs that these technological tools may fill. In the next few minutes, I will try to summarize in the most clinical, simple, and practical way possible aspects as complex as the gaps in lupus nephritis management, the biomarkers that these approaches have provided, and especially stressing in the pitfalls to address in order that omics strategies impact clinical practice in the near future. So let's start. As you all know, lupus is a disease that have enormous impact from the economical and social point of view. And lupus nephritis is an independent predictor for death and end-stage renal disease in those patients. But I want to stress in one of the hallmarks of lupus, and is the manifestations, the variability in the manifestation. And this variability may be between patients and in individual patients between different flares over the time. Moreover, SLA is a highly complex disease with multiple immunopathological disorders. The most significant from the renal perspective is the immunocomplex deposition, although autoreactive B cells are essential, and disease progression relies on the establishment of a systemic inflammatory environment generated by myeloid cells and T lymphocytes. But we don't really know many things about the kidney response to this autoimmunity. Outcomes in lupus nephritis are demonstrated that long-term results are encouraging compared with 30 years ago. Despite the use of the best available current therapies and achieving high levels of early clinical responses, unfortunately, the kidney often sustains long-term damage, and nephritis relapses affect over 50% of the patients. So the treatment paradigm of lupus nephritis is moving in an imbalance between when to perform an aggressive immunosuppression therapy and when to avoid toxicity. And probably this is related with the absence of good biomarkers in order to stratify the disease. When the patient are in risk of disease, of kidney disease, when the patient is in the preclinical disease, where it's mild disease, severe disease, or where we are in the end stage of the disease. So what is one of the important reasons because of is very important to try to approach this need with new technology. Moreover, predictor biomarkers of outcome in lupus nephritis correlate poor with prognostic in the long term. Overall, however, the absolute levels of these markers are changes in the levels do not accurately predict a disease flare or response to therapy. As you see in the table, positive predicted value is so low for C3, C4, and anti-DNA. What about plasma biomarkers? As you know, anti-ribosomal P antibodies, anti-chromatin antibodies, anti-nucleosome antibodies have all been associated with lupus nephritis, but the absolute levels of these markers and changes in their levels do not accurately predict a disease flare or a response to therapy. And what about kidney biomarkers? Biomarkers of kidney outcome, biomarkers of kidney damage or kidney damage related markers. So as you know, renal flare is diagnosticated by the increase in proteinuria or creatinine, abnormal urinary sediment due to active disease. Creatinine and proteinuria have a predicted value for the outcome of lupus nephritis, but they are not specific to detect lupus activity. It's important and it's a major finding from our clinical experience that a proteinuria cutoff level below 0.7 grams per day after 12 months of treatment best predicts good long-term outcome in patients. But this is probably not related, is not specific for to determine the mechanisms of damage. Positive predictor value was high, but negative predictor value is too low. Proteinuria, GFR, and urinary sediment are only indirectly related to the mode of action of the immunosuppressive therapy and often respond only after a significant delay that is not usually covered by trials that last 1 or 2 years. The duration of any kind of renal flare, proteinuric or nephritic, is the most robust marker of CKD. And this is an important finding in order to address omics technologies in lupus nephritis. I do not stop really in the renal biopsy after this the nice presentation by Dr. Garcia, but I have to say that renal biopsy is the gold standard in baseline assessment of renal disease, provides prognostic information, and influences initial treatment. But unfortunately, renal biopsy also suffers from the harshness of variability. And one thing we can learn about renal histopathology is that together is better. As much biomarkers we have, the specificity of the diagnosis of lupus nephritis improves. And that's an important message for the following slides. A repeat renal biopsy in lupus nephritis. I think that is an important topic. And as you know, and you really know well, active proliferative lupus nephritis requires intensive therapy. Histologically, more severe glomerular forms of nephritis cannot be predicted with any certainty from the clinical picture. So, repeat renal biopsy also has been used following induction therapy to evaluate, to assess the response of histological activity and the progression of renal fibrosis. So, what we need to try to do better treatments in our patients with lupus nephritis. So we need not a punctual picture to the phase 0, the genetic predisposition and the environmental trigger. We don't need a picture of how the autoimmunity develops. Probably it's important to have a picture of the moment in which the patient have acute kidney injury, and of course, the moment we have chronic kidney injury. But probably we need not a picture, we need the whole movie that allows us to understand in which moment any treatment is more effective. So lupus nephritis is a typical scenario in which transnational biomedicine could be useful. Transnational biomedicine is the process of turning appropriate biological discoveries into biomarkers and drugs that can be used in the treatment of patients. And in this case, just to summarize, in the case of lupus nephritis, there is uncertainty in how to use target biologic therapies due to the absence of stratification biomarkers to explain variable response rates in those patients. So searching for a panel of reliable biomarkers is a question of looking the whole movie, not for a picture. We need information online, in other words. And for that reason, I think omics could address some of these needs. Proteomics and metabolomics used to reach or bringing together biology, chemistry, and bioinformatics from a whole fluid or a whole tissue in order to extract information. And from another point of view, RNA single-cell sequencing is a method that allows the comprehension of genes and receptor expression in order to determine a predominance of cell population and cell differentiation. I do not stop in the technological explanation of these approaches because I think it's important to explain that from a clinical point of view. And I think the best example to explain that is pharmacogenomics. Pharmacogenomics is a study of the molecular or genetic basis of the disease to develop new treatment routes, to develop a good route, to find out drug not toxic and beneficial. Because you know that the same diagnosis and the same prescription could have completely different outcomes in different patients. So we need to address this using these new technologies. So what are we doing now? I will try to summarize some of the findings about biomarkers from a clinical perspective. We will start from biomarkers capable of identifying renal involvement. So I have to say that, summarizing in a few words, high urine concentrations of biomarkers are usually related to lupus nephritis activity, and low concentrations are related with healthy patients or patients with lupus without renal manifestations. With this concept, I have to say that the most robust biomarkers at the moment for the identification of renal involvement are MCP1, monocytic chemoattractant protein, and T-weak. And probably one of the key messages is that coupling T-weak and MCP1, we are able to discriminate lupus nephritis renal damage. We are able to discriminate patients with active lupus nephritis with poor outcome. And of course, the performance of these biomarkers improve if we merge this combination with renal function. This is proteomics evidence. And what about biomarkers for disease activity monitoring? So from a genomics perspective, we know that COL8A1 type 8 alpha-1 collagen gene that encodes for this protein is a good biomarker for predicting the loss of kidney function. But unfortunately, this is not a modifiable biomarker. It's not a potential therapeutic target. We have other biomarkers associations that are related with disease activity monitoring. So it's interesting to know that serum VEGF, vascular endothelial growth factor, and soluble TNF receptor 1 coupled with MCP1 in urine and glomerular filtration rate are a combination of biomarkers that have the best performance to monitorize activity of lupus nephritis at the moment. And also, in this case, we are talking about a proteomics finding. And what about biomarkers useful for stratifying lupus nephritis patients? So, from this perspective, cytokines related with interferon pathway are useful for stratifying lupus nephritis patients. But there are some pitfalls in this context. Transcriptomics and proteomics findings conclude that interferon plasma levels are transient and difficult to measure from a clinical perspective. For instance, higher levels identify patients with lupus nephritis proliferative classes, and lower values are more associated with pure class 5 lupus nephritis. Of course, also, we have some evidence from tubular injury markers. Urine and gall levels were more increased in patients with class 4 lupus nephritis than in patients with class 3, class 2, and class 1 lupus nephritis. But probably this finding is not robust enough to recommend the use of the urine and gall as a biomarker to stratify lupus nephritis patients. So, what we can do when we have an omics finding that could be interesting from a clinical perspective, but that technical is not feasible from a clinical perspective. So there are some recent findings from the precise sites studies that confirm that an elevated polyclonal free light chain levels reflects a strong interferon signature in patients with systemic autoimmune diseases. So probably we can use in the future elevated free light chain levels because they are associated with disease activity, with inflammation, and with a specific antibody profile, especially in patients with normal renal function. So probably omics findings could not be translated directly to the clinical scenario, but could extrapolate using a more handy test from the clinical perspective. And this is an example. And what about biomarkers for predicting therapeutic response? From a genomics perspective, GWAS studies find a series of genes that were useful to identify lupus nephritis patients who did not respond to treatment. There are some upregulated genes such as S188, BCAM1, and so on. These genes were linked to the immune response molecules, adhesion molecules, and receptors of cytokines or immunoglobulin superfamilies. And by the contrary, downregulated genes were related to tight junction and protein transport in the kidney, which remarks the important role of nephroprotection of antiproteinuric therapies in the field of lupus nephritis. From a transcriptomic perspective, we have also very remarkable and very promising findings. Interferon scores were also related to prediction of therapeutic response, and the upregulation of interferon pathway is a potential therapeutic target due to its close relation to pathogenesis, even if we know that levels of interferon in plasma are really variable and difficult to follow. From that perspective, it's very interesting to remind that rotalizumab, a drug that blocks the signal of transduction of type 1 interferon receptor via neutralizing all the 12 interferon alpha subtypes, reduce flares and decrease steroid use in patients with low interferon signature. By the contrary, anifrolumab and cifalimumab show greater effect size in patients with high interferon signature and in patients with severe disease. We have lots of huge information about biomarkers for predicting therapeutic response. Another aspects that I think is remarkable to mention are, for example, to talk about the modulation of NF-kappa beta activity by microRNA 190, which is coupled with the Clotho pathway. And it's important because it seems that this regulation for these microRNAs can lead to autoimmune response, contributing to the development of lupus nephritis. The potential involvement of certain microRNAs in renal fibrotic process of lupus nephritis make these molecules the possible predictors of treatment outcome, potential predictors of treatment outcome. Additionally, high levels of IL-17 may reflect severe therapy-resistant phenotype. And once again, urinary angle appears, coupled with the levels of angiotensin as a marker of responsiveness to treatment, besides being useful to monitor disease activity and severity. Finally, it's important to mention that T-weak levels 3 months after an episode of recurrence were described as a predictor of a complete response to treatment after 6 months of induction therapy. And what about metabolomics? Metabolomics address or try to find out the presence of markers of cellular dysfunction. There are a huge number of papers talking about the role of metabolomics in lupus nephritis, but I have to say that it's very preliminary information at the end. What are the pros of this technology? Usually metabolomics is performed using nuclear magnetic resonance and mass spectrometry that are very, very precise and very high throughput technology. But the most interesting aspect about metabolomics probably is the ability to connect several variables that we know that influence treatment in a patient: environment, lifestyle habits, disease characteristics. But unfortunately, have also the limitation that at the moment it's very difficult to understand or to address if metabolomic changes are due to lupus nephritis dysfunction or are treatment interference. So, in conclusion, being a polygenic disease, the pathogenesis of lupus nephritis varies among patients and animal models. So I think that animal models are not the best study approach for this problem. And it's difficult to correlate findings in animals with findings in patients. Study endpoints that relate better to the mode of action of the immunosuppressive drugs are important and will be the future for the proof of concept trials. The third conclusion should be that looking for biomarkers of autoimmunity using repeat kidney biopsy is a must to first demonstrate drug efficacy on the underlying immune disorder. From another perspective, it's important to mention that even if in situ formation of immunocomplements is the initial or the seminal event in lupus nephritis, the result of the renal pathological adaptation is an important finding and is the precipitant incident or probably the appearance of CKD. For that reason, we need to get to know into how this adaptation, these kidney adaptations have occurred, because perhaps the therapy should not attack the root of the cause, but guide the result of these changes towards a healthy state. And this is two remarks the importance of nephroprotection, the importance of control of the proteinuria. The hard road to ahead to sustain remission in lupus nephritis, of course, implies the use of transnational biomedicine workflows to reveal their underlying molecular signatures. But we have to struggle with a great number of pitfalls. Some of the most important are shortage of samples from untreated patients. It's very difficult to find out patients with lupus nephritis presentation that were not challenged with treatments or with immunosuppressive therapy before for non-renal manifestations. And it's important to address and use these omics platforms in a setting, in a scenario of repeat biopsy protocol, because it's fundamental to have baseline samples and then have samples to compare patients doing well with relapsing resistant patients. And from another perspective, we need to connect biomarkers from the perspective of the renal biopsy, from the perspective of the plasma, and from the perspective of the urine. At the moment, I think that the best way to address renal biopsy biomarkers from a molecular perspective probably is transcriptomics, usually using single-cell sequencing potential tool to identify inflammatory signatures, microRNAs, or gene expression molecules. At the end, we need to work together in a multidisciplinary approach in order to find signatures across lupus nephritis stages and try to find a way to get clinical significance of omics findings. Hopefully, initiative as the 3TR study, a European study, who is trying to find out or change the taxonomy of a new taxonomy of the lupus nephritis based on treatment targets and remission targets, could be answer some of the questions that I pointed out. But for the moment, we have to say that the quote for Dr. Osler continue to be real and present. And thank you very much for your attention.
Thank you very much, Luis, for making a little bit more clear this very complicated issue that certainly it is the role of omics in lupus nephritis, but it is certainly the future. This is the way that we will have in the future to address personalized medicine. And talking on this personalized medicine, we are going to have the last presentation. The last presentation from Dr. Gerard Espinosa will address probably the concept that we are facing nowadays, that we are probably now moving from sequential therapy to combination personalized therapy in lupus nephritis. Unfortunately, Dr. Gerard Espinosa from the Department of Autoimmune Diseases at the Hospital Clínic of Barcelona cannot participate directly in person in this meeting because he had another commitment at this time, but he sent a pre-recorded presentation that will be just online right now. So please, can you put the pre-recorded presentation?
Boa tarde a todos. En primer lugar, gostaria de agradecer aos organizadores deste incrível encontro por me convidarem a participar, en especial aos médicos Carlos Díaz e Carlos Vasconcelos. Lamento não poder comparecer ao vivo por motivos pessoais. Espero voltar a encontrar-me em breve nesta bela cidade que é Porto. Good afternoon, everyone. First of all, I would like to thank the organizers of this incredible meeting for inviting me to participate, especially Drs. Carlos Díaz and Carlos Vasconcelos. I regret not being in the Congress for personal reasons. I hope to meet again soon in Porto. I will share to my presentation. The topic of my talk in this round table of lupus nephropathy is the change of paradigm from sequential therapy to combination and personalized therapy. These are my disclosures. And let's go to the presentation. In the field of the immunosuppressive treatment of lupus nephropathy, where are we now? Well, all guidelines are in accordance in the fact that the immunosuppressive treatment of lupus nephropathy are based on 2 consecutive phases. The first one is the induction phase, with an intensive immunosuppression that is looking for an early remission of renal flare, with a duration of 3 to 6 months. Induction phase had to be followed by the maintenance phase with a low grade of immunosuppressive therapy. At this moment, the objective is to prevent renal flares, and the duration is at least 24 months. In most cases, 36 months, and a few patients will need long-term immunosuppressive therapy. But which is the best treatment to induce the renal remission in proliferative and membranous lupus nephritis? I'm presenting you the last version of KDIGO guidelines. As you can see in the diagram, corticosteroids plus mycophenolic acid or intravenous cyclophosphamide are the classic combined therapy. Following the results of the most recent studies, KDIGO guidelines also include the use in certain cases of calcineurin inhibitors together with mycophenolic acid, the so-called triple therapy, and belimumab as an odd therapy to standard of care, mycophenolic or cyclophosphamide. When the renal remission is achieved, in the maintenance phase, mycophenolic acid analogs or azathioprine are the preferred options. If these treatments are not tolerated, tacrolimus may be an option. In cases of refractory lupus nephritis, it is important to take in mind some points. First, to verify an adequate adherence to treatment. If you are not sure about the degree of activity of lupus nephritis, or the patient may have lesions of thrombotic macroangiopathy, consider repeating the renal biopsy. To consider switching to another treatment option, mycophenolic acid analogs to cyclophosphamide or vice versa. And finally, to consider the triple therapy, adding tacrolimus or other biologic therapies such as rituximab. With this classical current sequential treatment strategy, complete renal response is achieved in a disappointing proportion of 20 to 30% of the patients within 6 and 12 months from the onset of lupus nephritis in most clinical trials. 20 to 35% of the patients who achieve adequate disease control show renal relapse with the following 3 to 5 years of treatment. And more important, at least 20% of lupus nephritis of patients develop chronic kidney disease, and of these, 5 to 20% reach end-stage kidney disease within 10 years from the lupus nephritis onset. And not to mention the side effects of current immunosuppressants, especially the high risk of infection, which contribute to increased morbidity and reduced quality of life of patients with lupus nephritis. Therefore, how can we improve the results of lupus nephritis treatment? Well, the first possibility is to apply the treat-to-target strategies recommended for EULAR guidelines for SLE in the field of lupus nephritis. Following this strategy, we need to achieve an early renal remission and avoid renal flares in the evolution in order to maintain the renal function over time. However, the first problem is that we need to identify the optimal therapeutic target. In the last years, proteinuria has been identified as the main prognostic factor of long-term renal function in lupus nephritis, and therefore it is the current target of treatment of lupus nephritis. In fact, two prospective studies, the Euro lupus nephritis cohort at the left side of the slide and the maintain trial at the right side of the slide, have found that a proteinuria cutoff level of 0.7 grams per day at 12 months of treatment best predicts long-term renal outcomes in patients with lupus nephritis. And recently, these results have been confirmed in three real-world independent cohorts of patients with lupus nephritis. However, although the positive predictive value of proteinuria at 12 months of treatment is excellent, the negative predictive value is poor. In fact, there are different studies that have demonstrated discordant results between proteinuria levels and activity index and chronicity index scores in repeat renal biopsies. Our group published in 2016 this study in which in 35 patients with proliferative lupus nephritis and treated with intravenous cyclophosphamide, a second biopsy was performed after a mean time of 30 months. As you can see in the table, 9 patients showed proliferative lesion in this repeat renal biopsy, despite that one of them had complete renal response and 5 partial renal response. More interestingly, the probability of renal flare-free was much lower in the group with proliferative lesions than in the group with non-proliferative lesions, independently of the proteinuria levels. More recently, 2 European groups have published this retrospective study in which a repeat biopsy was performed in 42 patients with incident biopsy-proven active proliferative lupus nephritis after a median time of 24 months. The authors analyzed the histopathological findings in this per protocol kidney biopsy and tried to associate them with renal relapses and long-term function impairment with a median follow-up time of 107 months. As you can see, this figure showed the relationship between proteinuria and activity index in the repeat biopsy. Each circle represents one patient, and boxes represent patients with discrepant results between proteinuria and activity index. Specifically, the red box includes patients with proteinuria lower than 1 gram per gram and activity index score higher than 3. And the blue box includes patients with proteinuria higher than 1 gram per gram and activity index lower than 3. In other words, a significant proportion of patients, approximately a quarter of patients, showed adequate proteinuria levels, but with persistent activity in the renal biopsy. Interestingly, the authors analyzed the association between activity and chronicity index scores at baseline and repeat renal biopsies and the renal relapse and the renal function impairment over time. As you can see, at the repeat renal biopsy, activity index scores higher than 2 were associated with renal relapses, and this association was even more prominent for activity index scores higher than 3. In contrast, no association was seen between high or low activity or chronicity index scores and renal relapse at baseline renal biopsy. And chronicity index scores in repeat biopsies were not associated with renal relapse. And what about activity and chronicity index scores and renal function impairment? Well, you can see in this figure that no association was found between high or low activity or chronicity index scores at baseline renal biopsy and renal function deterioration. No association between activity scores higher than 2 or 3 at the time of repeat biopsy and deterioration of the renal function. However, there was a trend towards an association between chronicity index scores higher than 2 at repeat biopsy and kidney function deterioration, which became significant for chronicity index scores higher than 3. As a conclusion, high activity index scores in repeat biopsies may be predictive of renal relapses, and high chronicity index scores, mainly tubular interstitial damage, may be associated with poor long-term renal prognosis. In other words, Histopathological findings in repeat biopsies or per protocol biopsies may be very informative at the time of optimizing or reducing the degree of immunosuppression. To answer this very interesting point, REBIOLOOP study has been designed. REBIOLOOP is a prospective study that will include patients with an incident biopsy-proven proliferative or membranous lupus nephritis, treated with a standard of care, immunosuppressive therapy with either mycophenolate or urolupus intravenous cyclophosphamide. At baseline, patients will be randomized 1:1 to either undergo or not undergo a per protocol repeat kidney biopsy at month 12 from baseline. In patients with activity index score higher than 3 in the repeat kidney biopsy, the immunosuppressive therapy will be intensified based on the physicians and patients' shared decision. Patients who have not undergone repeat biopsy will be treated according to standard clinical parameters. Percentage of complete renal response at month 24 and renal impairment at month 60 will be compared between the two study arms. The second point to take into consideration to improve the treatment results in lupus nephritis is based on the findings of two recent randomized phase 3 clinical trials. In contrast to the classical sequential therapy of induction and maintenance phases, they are based on combination therapy with mycophenolate or intravenous cyclophosphamide and belimumab or voclosporin as add-on therapy, respectively, since the diagnosis of lupus nephritis. For time reasons, I will not describe in detail these two clinical trials. However, I would like to discuss with you some important points. In the first, the BLISS lupus nephritis study, belimumab was compared to placebo, added to standard of care, with mycophenolate or intravenous cyclophosphamide in patients with proliferative or membranous lupus nephritis. The primary endpoint was the primary efficacy renal response at 104 weeks, defined as an urinary protein creatinine ratio below 1.7 and estimated glomerular filtration rate not worse than 20% below pre-flare value or higher than 60 milliliters per minute, and no receipt of rescue therapy, resulting in treatment failure. As you can see, more patients who received belimumab plus standard therapy had a primary efficacy renal response than those who received standard therapy alone. Excuse me. In addition, a post-hoc analysis of BLISS lupus nephritis has demonstrated that belimumab added to standard of care appears to attenuate the risk of renal flare and renal function impairment, measured by decline of estimated glomerular filtration rate between week 24 to 104. But are we able to identify the patients in whom belimumab will be effective? Well, in the original clinical trial, belimumab achieved a significant difference in primary endpoint and in complete renal response, only in non-Black patients and in those treated with mycophenolate mofetil. This later point is important because patients in the cyclophosphamide and azathioprine group had a more severe disease profile, with higher levels of proteinuria, lower estimated glomerular filtration rate, lower complement levels, and longer disease duration at baseline. Moreover, African American patients are known to have a more severe disease course. More important, the post-hoc analysis of the BLISS lupus nephritis has shown that belimumab was efficacy in those patients with proliferative class of lupus nephritis. Conversely, in those with membranous or mixed class, belimumab did not achieve better results than the placebo added to a standard of care. Moreover, belimumab achieved significant results in those patients with baseline proteinuria, lower than 3 grams per gram of urinary protein creatinine ratio. All these data are very important and may add to the clinician to decide in which patients to use belimumab as add-on treatment to a standard of care. The second phase 3 clinical trial that I would like to comment is Aurora trial. In this trial, voclosporin was analyzed as a treatment of proliferative and membranous lupus nephritis. Voclosporin is a novel calcineurin inhibitor that was developed for treatment of lupus nephritis. It is similar to cyclosporin, but contains a modification that increases calcineurin binding. It has some advantages over cyclosporin or tacrolimus. In the case of voclosporin, the drug level monitoring is not necessary. It does not appear to have drug interaction with mycophenolate, and it may have a more favorable effect on lipid and glucose profile than other calcineurin inhibitors. In the field of renal diseases, calcineurin inhibitors have two properties: the reduction of cytokine T cells activation through calcineurin inhibition, and more importantly, the podocyte stabilization, which protects against proteinuria. The goal of the Aurora trial was to verify the efficacy of 23.7 milligrams twice daily voclosporin, in addition to mycophenolate and rapidly tapered steroids in the treatment of active class proliferative and membranous lupus nephritis. It is important that in this trial to highlight that all patients receive intravenous methylprednisolone for 2 first days, followed by the rapid oral prednisone taper from 20 or 25 milligrams per day, gradually decreased to 2.5 milligrams per day by week 16. The primary endpoint of Aurora trial was complete response at week 52, defined as an urine protein creatinine ratio below 0.5 milligrams per milligram, with a stable renal function measured by glomerular filtration rate and no need of rescue therapy at week 52. As you can see, more patients treated with voclosporin plus mycophenolate plus low-dose steroid achieved complete renal response at week 52 compared with placebo. The investigators tried to analyze the results, stratifying their patients according to different variables, such as sex, age, ethnicity, or if the patients have used mycophenolate at screening or the maximum dose of mycophenolate. As you can see in the table, results were not significant for the white race, pure class 5, and no mycophenolate used at the screening, that is, mycophenolate naive patients, and maximum mycophenolate dose during the study of more than 2 grams per day subgroups. In the light of the results of these 2 phase 3 clinical trials, the FDA approved belimumab and voclosporin for the treatment of adult patients with active lupus proliferative and membranous nephritis. However, it is important to take in mind that patients included in clinical trials are not the same of the real world. In the case of Bliss lupus nephritis study and Aurora study, patients with severe lupus nephritis with renal function impairment were excluded for the trials. At this point, and with all this data, how we can decide the best combined therapy for patients with lupus nephritis? Perhaps some factors such as the extrarenal manifestations, such as arthritis, skin lesions, serositis, or pregnancy issues, or clinicians' experience, patient's ethnicity, histopathological class lupus nephritis, baseline proteinuria, drugs availability and drugs cost, or the patient's preference may ask the clinician to decide the best combined therapy. And in the next future, we'll be able to design a personalized lupus nephritis therapy for each patient. To answer this question, we need to identify better therapeutic target based on biomarkers and the histological, urinary, genetic, cellular, and serological levels through the omics study. This study allows us to move from the current clinical categories of patients to clusters of patients in the future based on these omics biomarkers. In other words, from biomarkers with poor predictive value to biomarkers with better predictive capacity to allow us to design better tailored therapeutic strategies. Thank you very much for your attention.
Thank you very much, Gerard, for this very nice presentation, very important for clinicians to answer this or to find the answers for these questions. So we are going to proceed now to the question and answers, to the discussion. Also, I have to say that if you have any question for the specific talk of Dr. Espinosa, either Luis Quintana or myself, we will try to answer these questions. Maybe Carlos, you can help us from questions from the auditorium.
Questions from the audience. Who wants to put the questions? Raquel Faria from Hospital Sant Antonio.
Hello, Ricard, and all the round table. Thank you so very much for your presentations. I have a provocative one for all of you. When do you think we will no longer need kidney biopsy?
Really, thank you very much, Raquel. This is very provocative. I don't know if Luis wants to to answer, because he probably is looking for these biomarkers in order to avoid the kidney biopsy.
Yes, I think it's really provocative, and it's really an important and hot question. But I think we are really far away to do this, because from the point of view of the biomarkers, from the therapeutical point of view, I think the last slide from Dr. Espinosa was really illustrative, because we need to do a new taxonomy of the disease. We need to do a classification of the disease based on the therapeutic response. And for that, for the moment, we need the biopsy. Of course, it's clear that probably the repeat biopsy protocol is not useful for all the patients with lupus nephritis, but probably this 20% of patients that have high risk of progression needs to do it. And I think we need many years before to point it out the option of not to perform renal biopsies.
More questions from the audience? Carlos Vasconcelos.
Hi, Ricardo and colleagues.
Hi.
Very good talks. Thank you very much.
Thank you.
The question, our nephrologist colleague said that we are far away from in relation to kidney biopsy. But the problem is that we are living with new concepts, the new taxonomy, the different immunopathways, the T2T, the treat to target strategy, but we are dealing our patients with the classical induction maintenance, and classical maintenance treatment. And because we are getting delayed information about the results, we are not doing the best for our patients. Damage could be installed. And because you see, you have 3 months of MMF, 3 grams, and then go to 2 grams, or if you want the classical, mixed classical NIH protocol. But the response, you have a partial response, but the main is at 1 year, less than 0.7. So I would prefer the provocative proposal from the Professor Cameron, the nephrologist, some years ago, where you would maybe prefer not induction maintenance, but several inductions every time you have a need for that. What do you say? Because T2T in kidney, in lupus nephritis, we are far away. Indeed, we are far away.
Thank you very much, Carlos. It's a pity that we cannot be together with you in Porto at this time, but thank you very much for the question. I will let Luis to answer first, and maybe I will give my opinion later. Luis?
Okay. Well, no, I think it's a very smart and important comment. I think we need to address the problem in a different way. For example, probably perform biopsies is an issue. But for example, I think that how Dr. Vasconcelos said previously, expose the patient to steroid when it's not necessary is also a danger. So maybe we are in the phase we have a new group of therapies, new options of therapy that we need to manage properly. What we need to do to try to find out in which stage of the disease is the patient. And for this, we need better biomarkers and probably repeated biopsy in order to assess treatment response. Another point of view is that we now, from a renal perspective, have also treatments that are not directly related with lupus, but are related also with protection of the kidney. And that was one of the points I want to address during my talk. Is equally important to stop the activity of the inflammation due to the lupus than stop or halt the progression of the damage at the kidney level. And for the moment, the best way to go in order to avoid this, to protect the kidney, is to control proteinuria. Of course, below 0.7 grams a day, but if it's possible, below 0.5 grams a day, because we have experience from the other native kidney diseases and from the transplant from the transplant kidney pathology, that is the best predictor of good renal outcomes.
Yeah, thank you, Luis. I fully agree with you. And also I agree with Carlos that with the current therapy, with the induction maintenance, the so-called sequential therapy, we are far away of good follow-up, of good treatment of our patients. And it's a pity because, as you know, we were who proposed this therapy some 30 years ago in the late 80s, together with Fred Usiu and David De Cruz and Graham Hughes, working together at the time at the lupus unit at St. Thomas's Hospital in London. We proposed with the yellow lupus regime this sequential therapy that for 30 years has been, let's say, the standard of care in lupus nephritis. But we have to admit that this has been probably better than the previous therapies, but we are far away of having enough good treatment for our lupus patients. And I think that the solution to this will be, on one side, certainly to improve the knowledge on the biomarkers, the omics, but then to give the personalized therapy according probably to the omics or to phenotypes. Maybe so at this moment, according to some phenotypes, because the omics are probably not enough developed. And I think this will be it's not just to repeat the induction every 6 months, but to do since the beginning, probably a combined therapy in addition to either cyclophosphamide or mycophenolate and steroids and obviously antimalarial therapies, to add belimumab, to add rituximab, or to add voclosporin, or to add anifrolumab, or to add any other biological therapies, depending on the personal characteristics of the patient. I think this will be the future, together with, as Luis clearly stressed, nephroprotection. Really, it's very important to add since the beginning the new therapies for nephroprotection. I think this will be the future, more than to repeat induction and maintenance therapy every 6 months and so on. What do you think, Carlos? Do you agree, or you still think that we have to repeat induction therapy every few months.
Question, Ricard, is that while we are expecting the new biomarkers, we are waiting for a long time. We are doing the classical way, and it happened with me. I did the Euroloops. Yes, we did the Euroloops, and then after the 3 months, we switched for maintenance, and we stay with not a full, even if we don't have a full response, we go ahead to the maintenance therapy. And the question we should put is, why don't you try? Because patients are different, clearly, why don't you try to keep some induction, let's say, to get a full response before go ahead to maintenance. That's my point for nowadays. But I agree with you both, of course, for future.
Yeah, but the proposal is since the beginning to do something else than just probably the Eurolupus or the mycophenolate induction regime. In some patients, probably not all of them, probably some patients will be enough to give the classic induction therapy. But for other patients, probably to add something else. The question, I agree, we don't have the omics at this moment to decide which patient to add belimumab or which patients to add voclosporin. So probably we will have to do this according to what we have now. The phenotype, the kidney biopsy, the diagnostic kidney biopsy, maybe if there is a class 5, very florid class 5, maybe you can add since the beginning voclosporin. Maybe if you have a very active class 3-4, you can add since the beginning belimumab. So that's, we have to use probably what we have at this moment while we are waiting that omics probably will improve the personalized medicine. And again, I stress, maybe Luis, you have probably to push even more. Nephroprotection. There are new drugs now for nephroprotection that we have to use.
As I want, if I can, I want to add a comment because Dr. Vasconcelos stressed a very important point. Probably we need to go to demand a complete renal response in all the patients. That's the point. And until we don't achieve this, if the patient have no important chronic renal damage, then we have to add the new option we have and stress and improve the nephroprotection. And I think in the few next years we will see improvements because we have new drugs to protect the kidney that are well tolerated, and we can combine the old and classic RAS blockage with drugs that blockage angiotensin 2 receptor, for example, with the inhibitors of the canal ionic at the 12 proximal ISGL2. We are having very good experience with these drugs, and many times I think we need to stress in protect the kidney, control proteinuria, and avoid to expose patients to steroids when it's not necessary. That's another point. So if we save steroids and we combine classic medications with the new medications, for example, belimumab with mycophenolate or with cyclophosphamide, probably in the near future we can have better results in the hope that we have a panel of omic biomarkers in the new future.
Ricardo, we have another question. António Marinho.
Hello, I'm Antonio for Porto. Hello, Ricardo. Thank you so
Hello,
much
Antonio.
for this
Hello.
nice presentation. I had to review these papers a few weeks ago for our Congress, and I have one or two questions for you. One is directly, do you really believe that belimumab works on lupus nephritis? When I saw the paper, I was looking for doses of MMF and for the proteinuria patients. And I believe that they are using less MMF, less CellCept than the ALMS trial, the original one with the CellCept. And the placebo group had more proteinuria than the group that used belimumab. Specifically, they have more standard deviations of more than 2, and the group that were using belimumab was almost 2.5 without standard deviation. So that was, I think there was something driving for the more severe group on placebo. And when I looked for the oldest trials, I always look for the LUNAR that has been, of course, a bad trial. They really had very bad patients, and the very bad patients did well after 2 years of treatment with rituximab and the standard of care, but just at 2 years, not at 1 year. I'd like to hear some comments about that, and do you really believe that is the good idea or not?
Well, thank you, Antonio, for addressing these topics, because really there is an issue, and the limitations of the belimumab trial have been clearly stressed by you now, and even at the editorial that accompanied the New England Journal of Medicine paper by Fred Usiu. That's right, there are several limitations. And I have to tell you that belimumab is very lucky, because all the trials that have been performed before lupus nephritis, in general lupus, all the trials that were performed all were positive, all managed to obtain a significant statistical significance, a p-value, that is what all the drugs are looking for. Although I certainly agree that the trials have these limitations, I think that it is a good drug. It really improves lupus nephritis as it improves other manifestations in lupus patients. This is not the final solution, for sure. We will need probably better use of the therapies and beta therapies in the future, but I agree. I think that really it's beneficial, and it's a step further. It's an improvement in the management of lupus nephritis. We will probably have to clearly know which patients will benefit. Gerard Espinosa has in some way tried to do this. Mention probably those patients with more active class 3 and class 4 lupus nephritis. Maybe also, I always, in the practical clinical point of view, in the day-to-day clinical management, I have a subset of patients are those with low compliance, low adherence to treatment, usually young adolescents, young ladies, that maybe if you send home with just taking pills, you are not confident if they will adhere to treatment. If they come to the hospital to put intravenous belimumab, probably they will work better. So there are different subsets of lupus nephritis patients that I think that really belimumab will benefit them. Although I really agree that we need still better therapies. The problem of the moment that we decide to analyze the results and to put the endpoint 1 year, 1.5 years, or 2 years, this is certainly very, very difficult. And I have to tell you that some trials have failed just because the moment they decided to put the endpoint, the primary endpoint, was the wrong moment, because if they would choose probably another time for the final endpoint, the trial would succeed. But this is something probably sometimes is a question of luck. I think that although even also ourselves, we did the study that found that the figure that we have to keep in mind is 0.7 or 0.8 grams in 24 urine proteinuria at 12 months. We probably now believe that we cannot wait until 1 year to make changes in the therapy. So again, it's very difficult to say which is the best moment for a trial to decide when the primary endpoint should be taken. 1 year, 1 year and a half, or 2 years, and sometimes it's just a question of good luck.
More questions from the audience? Ricard, we have no more questions from the audience.
Well, if there are no more questions, I think that we can end this session. But before ending, I think that there is an important question also for Adriana, that is, as you probably have seen, it is very important to have in the team a nepropathologist. Kidney biopsies are essential. We in our group, and we stress this always, we like to perform kidney biopsies as much as needed, obviously for diagnosis, but also for follow-up per protocol and so on. And this is very important. We need a good nepropathologist to assess this biopsy, because otherwise it's a waste of time to perform biopsies if nobody is going to do a good reading of the biopsy. And the question for Adriana is, now with the new recommendation or the new classification criteria of lupus pathological findings, do you think that it's easier for pathologists to read the kidney biopsy? Because one of the issues is that maybe two pathologists are in front of the same biopsy and they say different things. Do you think that with the new classification, everything is clear? You know really what to do, and if next week you are on holidays and there is another pathologist reading this biopsy, will say exactly the same that you?
Thank you, Ricardo. Telling the truth, the definitions that are coming with this new review of the classification improve our understanding about some lesions. But the problem is we have a biopsy that have serial cuts, staining with different things, and it's very difficult for the human eye decide in which point do you measure the lesion. And I want to say that pathology has much room for improvement with the use of artificial intelligence. I think this is the future for the kidney biopsy, and this allows to break the problem of the inter-observer, the not inter-observer agreement.
Thank you, Adriana. This is really probably the future. This artificial intelligence for reading. We know CT scans, X-rays, and so on, and also for reading the pathologies, the kidney biopsies. Well, Carlos, if there are no more questions,
you can close the round table.
Thank you very much. Thank you very much, Luis. Thank you very much, Adriana. Thank you very much, Gerard, although you are not here in person, for these really very nice presentations. And I hope that we have given to the audience the idea of the importance of having a team in the management of lupus nephritis, a team composed by nephropathologists, nephrologists, and autoimmunologists dealing with lupus patients in order to make the better diagnosis and the better treatment of our lupus nephritis. We are facing a change in the paradigm in the diagnosis and management of lupus nephritis. These are very exciting new times. A new era is in front of us. Hopefully, this will mean a better treatment, a better prognosis for our lupus patients. Thank you very much also to the audience, and especially thank you very much to our Porto friends, to Carlos Diaz, Carlos Vasconcelos. We hope that next year we will be able to join again in Porto and to enjoy again with this meeting. Thank you very much.
Thank you, Ricardo. Thank you.
Thank you very much. And next time, face to face. Thank you.
Thank you.
Thank you very much.
And this is the end of the Congress. If you want.
We are announcing that the next PAM Med Interna, if we were alive, will be.
Are you listening, Ricardo?
Oh, yes, will be 8 to 10 September, because 2 to 5 October, we have the Internal Medicine National Congress, and then 2 November, we have the ACR. So I think that 8 to 10 September would be nice to have you here also, Ricardo.
Ricardo, put in your agenda.
I will put in my agenda. Thank you. 6 to 8 September. Okay.
8-10.
8-10. Sorry, 8-10 September.
Thank you.